Transperineal mapping biopsy has several advantages over truss biopsy. It samples the entire gland, it documents areas of multifocality, and it's an accurate method for intraprostatic staging. Its disadvantages are it's time-consuming, requires anesthesia, the needle and gun are limited to 17 to 20 millimeters in specimen length, which require multiple inline biopsies. The solution for a better biopsy should include mapping software that directs the biopsy sites and records their locations, which can be used for targeted focal therapy, a variable biopsy needle and gun that will take one sample from apex to base, and an integrated pathology system that secures a longer specimen for the pathologist. The procedure is performed in the OR using equipment similar to brachytherapy setup. The software includes a planning and biopsy phase, a treatment phase, and a review phase. The software is connected to a video capture device. The urologist begins the procedure by scanning through the prostate starting at the apex and working his way towards the base. These images are captured by the image capture card into the program. The urologist or his assistants can use a computer that has a light pen so he can trace the contour of the gland using a touch screen. Alternatively, instead of a touch screen, the urologist can sit at a keyboard and trace the contours of the prostate as demonstrated here. On each axial slice, the urologist or his assistant traces the contour of the prostate starting at the base of the gland and working his way towards the apex. There are several tools available to the urologist that allows him to fine-tune the contours, including smooth contouring or nodal adjustments. It's important to correctly identify the border of the prostate so the 3D image reconstruction accurately reflects the prostate gland. The urethra can be added, and once the structures are entered, the biopsy plan is designated, needle length is chosen, the margin from the capsule and the urethra is selected, and whether or not the needle should enter the prostate and either penetrate the posterior or the anterior aspect of it. Now the biopsy plan has been generated and it is reviewed both in the axial and in the 3D reconstruction. During this phase, the urologist can choose to add or delete certain needles, for example, if they're too close to the urethra or there appears to be a gap between needles. The urologist now inserts the first needle through the template, takes a biopsy. The probe is rotated to image the second needle, and the urologist will then insert the biopsy gun into the designated coordinate while simultaneously imaging the position on the software. Here the needle is seen entering position number 2. Notice that the needle is slightly off from the virtual image. It's important for the urologist to move the virtual needle to overlie the actual needle so the representation is accurate. This is done not only in the axial image but also in the sagittal image immediately before the needle is fired. The needle is brought back to the apex and fired, and the needle is then captured. Here is another needle showing 2 inline needle shots, one at the apex to the mid of the gland and the second one from the mid of the gland to the base of the gland. This is necessary with the current needle technology because the needle length is only 17 millimeters and the length of the prostate is twice that length. Here the urologist is going to take a biopsy posterior to the urethra. The needle is inserted into the gland. The virtual needle is aligned. Imaging is switched to sagittal. The needle is aligned in sagittal to the virtual needle and the biopsy is taken. This image represents the pathology phase showing 8 lesions. The 4 lighter colored lesions are Gleason 6, as represented here in the dialog box, and the darker colored lesions represent Gleason 7. Here you can see a Gleason 6 lesion is extremely short. Here's a slightly longer Gleason 7 lesion. The left side of the blue represents the base of the gland and the right side represents the apex. Now we are rotating the image so you can see the length of the cancers from the base to the apex of the gland. This is the information that will be used for the focal therapy. Here a patient is getting targeted cryoablation of a number of lesions that were identified by the mapping program. The cryoprobes are inserted into the lesions and the ablation happens just at the lesions. The middle image here shows the final needle chosen for the 3D biopsy procedure. Notice the grooves which help hold the tissue. This is the 3D biopsy gun. The orange dial at the back adjusts the length of the shot between 2 and 6 centimeters. There is a service life indicator. The gun is a reusable device and the needles are disposable. Now we're demonstrating one of the advantages of the pathology device developed by 3D biopsy. Under normal conditions, many biopsies are taken of the prostate. These have to be individually handled by the technicians, which causes damage to the specimen and can cause confusions. The integrated pathology device allows a specimen up to 6 centimeters in length to be secured in a substance that holds the biopsy material by a folding over mechanism that secures the specimen and allows it to be handled by pathology as one.